Hi, welcome you all to another episode of Dent-Talks. I'm Dr. Eapen Thomas, Professor and Unit Chief of Department of Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences, Thiruvalla, Kerala. And today we will be discussing on the complications in day-to-day dental practice, in your routine dental practices. What are the possible complications that you can come across, and what are the methods to manage in it? You might be the best of the dental practitioner around. You would be the one who's having the maximum experience. You could be confident in doing anything. You would be very much skilled. You would be very much thorough with your theoretical knowledge. But complications are inevitable in practice, and one should have a thorough understanding about the whereabouts and the causes and the reasons of all these complications so that you can manage all these very well and be very efficient in your practice and you can excel in practice. Now, what are the topics that we are going to cover today? Post-extraction bleeding, a little bit about the TMJ dislocation, dry socket, bone fractures, which include maxillary fracture, trismus, accidental avulsion of tooth, postoperative anesthesia, oro-anal communications, and these are the things that we're going to discuss. Let us first take up management of bleeding. This is indeed an alarming situation for most of us in practice. Could be happening in various situations. This is just in a picture of a patient who's had a bleeding episode. This has happened intraoperatively during when placing an incision. It just bled like anything, and it is something really an alarming and panicky situation for us. So basically, if you know how and when and how to control all these things, it's very easy to manage all these complications. I just wanted to show you because this could be one of the possible most, like panicky situation that most of us would face. Now let us see what are the problems associated with the bleeding or what are the things I should look for. It could happen, the bleeding could happen either from the extraction site. Okay, it can be either in the intraoperative period where in which you extract or you do some manipulation in and around the tooth, or it can happen later after you discharge a patient or after you send a patient with the postoperative instruction and the pack. It can happen to you while you're placing incisions. Suppose you're doing a transsalivary extraction, you happen to have an open method. While you place an incision, sometimes that could end up in severe bleeding depending upon the location. And bleeding can happen in any of these patients who's having, hypertension, and basically based on the stress and anxiety what you create in these patients, they could have a raise in the blood pressure, and that could lead to BP or bleeding. Patients on antiplatelet drug is again another one of the reasons which could actually end up in postoperative or even intraoperative or delayed bleeding. Now, what to look out for in case when the patient is complaining about bleeding or post-extraction bleeding, a patient is reporting to you. What are the things that you should look for? First, you should see what is the site of the bleeding, what or from where all this extraction bleeding can happen, that you should be having an idea about it. Extraction bleeding can happen from the socket base, okay, from where in which there could be an accidental perforation on the floor or the apex of the socket. It could be from the socket walls. Sometimes when you actually extract the tooth, you actually expand the bony socket walls, and if you don't compress it, what happens? The interradicular bony fragments do not get compressed, and there could be bleeding from the nutrient vessels on the socket wall. So that's one of the reasons very important regarding compression the socket after extraction. Well, it could be from gingival margins. If you are extracting your tooth in the inflamed areas, there could be possible postoperative gradual ooze from the inflamed gingival margins. And it could, what are the types of bleeding? What are the types of bleeding also you should be able to know. And arterial bleeding is something which actually keeps on pulsating, which is bright red in color. It keeps on pulsating. But a scapulary is not that sort of a bounding. It's a little bit less brighter, but of the slow, oozing type. And whereas your the venous type of bleeding is basically a little purplish color or a very dull red color, and which is very slow in consistency, and which is very slow in the way how it is spurting. So why I asked you to know about this, if you know the site of the bleeding, if you know the type of the bleeding, then you can actually target on the type of management of bleeding. Without knowing the site of the bleeding, without knowing the type of bleeding, there is no point in just blindly going with a pack or putting some sort of medicaments there. If you know exactly the reasons and from where it is bleeding, just try to target in that particular area, find where it is bleeding, and then try to manage it accordingly. What could be the cause of the bleeding? That's again something that you should be having in mind. Now, there could be granulation tissue. Sometimes there's a chronically inflamed periapical inflammation on a tooth, and you've extracted the tooth, and there could be granulation tissue at the root apex, which have not completely come out with the extraction. That could get retained in your socket, and then that could be a common source of postoperative bleeding. But nutrient vessels, I told you, when there's an extraction of the socket, you're expanding the socket walls, and then if you don't compress the socket walls back, the socket walls actually, which is actually expanded, creating micro cracks, creates a little bit of oozing from the nutrient vessels which is passing through. Bone chips or any of these, if you left behind, also can cause a little bit of a bleeding or a gradual bruise by creating wound there. Tissue trauma, if your extraction is not done in an atraumatic manner, if there is so much of a tissue trauma by holding or grabbing the forceps, the tissues, it can get cut here and there, and then post-operative oozing or bleeding can be there. When you place incisions, if you have not actually had an idea about the anatomy or the place where you place incisions, if there's an advertent cut of any vessels, there's a possibility of bleeding, especially in case of a lower third molar impaction or lower third molar surgical extraction. As you know, this particular area, the distal aspect of the seven, we mostly put a releasing incision vertically running down. If there's a vertically releasing down incision is gone beyond the vestibule, there's always possibilities of endangering your buccal artery as well as the facial artery, which is quite deep inside here. So always these things has to be kept in mind when you place an incision also. Any of these could be the reasons why there is a post-operative bleed or intraoperative bleed, depending upon what type of a complaint is the patient coming with. Well, this is again the possible thing. Suppose when you have a third molar or a impacted third molar or a deeply root embedded third molar, and you're doing a transvalvular extraction, inadvertent cutting of the apical area or apical to the bone, the floor can be done with a burr and then can create sort of a bleeding while damaging the inferior vessels. Then, of course, in the lower premolar region, sometimes when you transect the deeply buried part, there's a possibility that you can endanger the mental nerve and the vessels. Again, these are the anatomical structures that you should keep in mind. And of course, in the lingual side, on the third molar, lower third molar area, sometimes there's a possibility that you endanger, you come across the retromolar vessels, which is actually seen on the retromolar pad or the retromolar area distal to the bone. And again, another one possibility is if you extend your incision much more lingually, you could actually injure your lingual nerve, but then that's not connected to bleeding. So this incision part is very important as far as retromolar vessels is concerned. Then, of course, the other areas where you can come across problem is the greater palatine area. And the palatal aspect, suppose you happen to you end up with a fracture of the palatal root and then you want to surgically remove it, you raise a flap, you haven't done properly, then you input your instruments, and there's a possibility here the instrument can injure, or even if you place a flap or incision also, and incision can actually injure this greater palatine vessel, which could lead to severe bleeding. So never place an incision vertically along this way. And whenever you are handling these instruments in this area, make sure that you don't actually inadvertently also disturb or disrupt the blood vessel, which could lead to severe bleeding. Of course, anteriorly in the palatal aspect, in the nasopalatal foramen area is again another one anatomical area. Sometimes when you try to extract a mesodense or something of that sort and you try to raise a flap here, there could be an inadvertent bleeding from the nasopalatal fossa and the incisive canal. And the nasopalatal neurovascular bundle also can give rise to troublesome bleeding. So you should be very careful when you're dealing with these areas. And of course, I told you the buccal vessels or the facial vessels, when you place a releasing incision in relation to the distal aspect of seven, when you slope it down into the vestibule, there's a possibility to injure the vessel. So these are the main anatomical areas which could actually give rise to bleeding. So in these areas, whenever you place an incision or whenever you manipulate, please keep in mind, please bear in mind about this anatomy so that most of these complications can be avoided. Complications always, just remember about that. Now, prevention is always better than cure, as they say. So if you know this anatomy, you can very well deal with it and you can very well control. Now, how to manage? Let us come to the management part. Now, patient, suppose, is coming to you as a post-operative bleeding later, okay, about say 4 or 5 hours after extraction, you reach home and then you get a call from a patient telling, sir, I'm severe bleeding from the mouth, there's a lot of blood in the mouth, and you ask the patient to come to the clinic, and then the patient might be coming with a lot of, clot, very frothy clot inside the mouth, fully covered inside the mouth. Then the first thing what you should do is, you should remove that clot from the mouth inside whatever is there, then give a local anesthetic first. Because why? Because the pain always induces anxiety in patients. So pain and anxiety again together can cause a rise in the blood pressure. So the resultant or the existing bleeding condition can be worsened. So always give a local anesthetic. And if the patient is a real hyperpatient or hypertensive patient, try to give an anxiolytic, maybe 0.5 milligrams of alprazolam or 0.25 milligrams of alprazolam, depending upon the body weight and the structure of the individuals. So that will actually reduce the anxiety, and a local anesthetic will reduce the pain in that area, so that the pain-induced anxiety and the resultant rise in blood pressure will be very much controlled, which will be prevented. So I told you, clean up the clot nicely, just debride the area, okay, just with your saline, whatever it is, keep your hand, your suction ready, portable suction or other type of suction, whatever it is, keep it ready, and you remove all the clot from the patient's mouth, and then you have to place a fresh pack, remove that, and just try to keep a fresh pack first. In the meantime, check the patient's blood pressure, because most of the patients, without checking the blood pressure, don't even try to control bleeding, because you don't know the underlying cause could be an raised blood pressure. So that has to be checked first. So any patient complaining or reporting in the clinic with post-extraction bleeding should be first, clear of the clot and kept back inside so that it doesn't bleed that time, and then immediately check for the blood pressure, because if the blood pressure is high, whatever measures you do, the bleeding is not going to come down. Then you have to resort to measures to reduce the blood pressure, and then only continue the other part of your investigation. In the meantime, you can also take blood samples and send it for your bleeding time, clotting time, your PTT and INR, because these are the blood parameters which can affect the patient's bleeding profile. So that's again in addition to while you're in between your checking the patient, you can actually, if your sister is good enough, or if you have facilities nearby, just call them and just take the blood sample and then get these blood parameters done. In the meantime, then definitely the next what you do is you have given anesthesia, you check the PP, you have given the blood for your so-called testing to do the bleeding profile. The immediate next thing what you should do is just debride the socket, because I told you, the possible sites where it can bleed, the possible reasons also what it can bleed. So if you have checked the BP and if you have found that value to be within normal limits, then there's definitely some other reasons. The other reasons could be any of those which I mentioned in the previous slide, the reasons or the areas where it can bleed, or it could be this so-called the bleeding parameter, some problem, because for that we have to wait for the report to come, because you have just given the blood sample. So in the meantime, you debride the socket nicely. There could be some granulation, something which you have overlooked while extraction. Nicely debride that area, okay, irrigate it very well, and just try to see the site of bleeding. I told you earlier, you should always observe and find out from where it is bleeding and what type of a bleeding. If you know, like it's not a pulsating, and if it's basically it's very obvious the site, then just localize in that particular area, and we'll try to control the bleeding from that side. So once you observe the site of the bleeding, if it's possible, sometimes you can give a digital pressure or a fresh pack in that area, and then try to control the bleeding so that it might do. So one thing what you should keep in mind is any bleeding from the oral cavity, if there is no associated systemic disorder. When I talk about systemic disorders, what I mean is any hypertensive or patient on antiplatelets or anticoagulants, any other bleeding diathesis, all these, if none of these are present for the patient, then every cases of bleeding, any case of bleeding can be very much controlled with the local measures. That should be something which should be assuring you all. So when you have ruled out all the systemic diseases, then it's something which can be controlled. Well, now certain areas, depending upon the site of the bleeding, you can apply local pressure. For example, if the oozing is from the palatal aspect or the bleeding is from palatal aspect, you know that the palatal, there's only one vasculature in the posterior area, that's the beta-palatine, and the anterior premolar to premolar area, there's only one vasculature, it's mesopalatine. And you know where the beta-palatine is, and you know where the mesopalatine is. So if that is only source, now you can apply digital pressure that site, so that will immediately stop the bleeding. So there are two things in that. One, you can actually make out what is or where is the cause of the bleeding. When you compress, if that bleeding is stopped, that means you are sure that the beta-palatine is the cause. So apply digital pressure, definitely that will stop, unless patient is having, I told you like earlier, systemic diseases. Well, gel form in extraction sockets, suppose once you have cleared the socket, you have nicely debrided it, you have seen for the bleeding, you can't actually exactly make out, but there's some slow building up. So one thing for sure is, it's not an arterial bleed, it could be a venous slow ooze, promising and assuring for you in terms of management. So in such cases, you can actually place a gel form. Now, when I tell you how to place a gel form, and adrenaline should never be used. This is what I have put in your star. What I meant is basically adrenaline should never be used as a vasoconstrictor property to control bleeding. Why? I'll tell you, because patient who's coming to you in the department or in your clinic with the post-extraction bleeding, we don't know how the blood pressure is. Adrenaline is a potent vasoconstrictor, as well as its stimulator of the heart. It increases the blood pressure, it increases the force of contraction, and it's going to make things worse. The bleeding is going to get worse. But definitely local aspect of adrenaline is there. That is the one thing, the positive part of that. If you apply adrenaline, definitely ambule veterinary. If you socket a little bit of gauze and apply there, the local bleeding, if it is from the gingival margins or anything of that sort, it will definitely stop. But the disadvantage is the moment it gets absorbed in the system of circulation, it's going to bounce back with the reflex rebound mechanism, and you're going to end up with severe bleeding later. So it's not that advisable, not at all advisable to use adrenaline in patients, especially if the patient's hypertensive. Definitely, adrenaline should never be used. So use a gel form dipped in saline. Once this is done, then you can actually place a suture if the suture is not done, because if the gingival margins, if it's very well approximated, so if the margin is by the point of whose amount of bleeding it is, so if you approximate the tight suture, that itself will be good enough to get a good hemostasis. Then give a moist gauze pack or a cotton bag. Never give a dry gauze pack or a dry cotton bag, because the moment patients start biting on it, and after some time, when a patient tries to remove your cotton pack from the site, then it tends to bleed because the fibers get stuck to the cotton, it's the blood clot there, and then can give rise to more complaint and post-extraction bleeding. So always go for a moist gauze or a moist cotton. So that's where you have to keep it in the patient's mouth and make the patient bite. Ice pack will definitely help in case, it will reduce or induce a little bit of vasoconstriction at that site, and will actually help to reduce bleeding. So these are the things that you should keep in mind as far as management of your bleeding is concerned. Okay, you have to first, I told you like earlier, control the patient's pain with the LA. As the patient's coming, then nicely clean up the mouth, and then nicely suck all the debris, everything like that. Keep a fresh cotton and make the patient bite so that it doesn't ooze at that point of time. In the meantime, check the blood pressure, then send a sample of the blood for investigation to rule out any sort of systemic diseases. Then open up the mouth, debride, start from one point to the other, try to isolate and locate the type size of site of bleeding, and manage it accordingly based on that. If it's like uncontrolled bleeding or a slow oozing from the socket, which you can't make out, you can place a gel form inside. If it's from the gingival margins, you can actually apply digital compression, or you can place a nice tight suture. Then if it's from the socket, you can place a gel form, and then you can place a nice cotton pack on top or a moist gauze pack on top with an ice pack. You can make the patient wait till the report comes. If the report is also fine as far as your bleeding parameter is concerned, there's nothing or no cause to worry. So that is one thing I have to tell you about bleeding, because as long as there's no associated disorders, any bleeding from the oral cavity can be controlled by local measures. Let's move to some commercial preparations which can be used. These are all anti-fibrinolytics. Basically, they work on the principle of prevention of lysis of the product, because sometimes the fibrinolytic agents comes into picture, and that is something which actually lyses the clot and causes the bleeding. So these type of drugs, commercial preparation might help you in controlling if it is something connected, if the bleeding was something connected to the lysis of fibrin, then these anti-fibrinolytics could be of help. That's a dosage how it can be used. You can take a detail from the slide. Well, etamicetate is again another preparation which acts in similar anti-fibrinolytic mechanisms. Again, that is also available as various tablet preparations, and various methods, various type of agents are available in the market in the commercial form, which can be used in patients. These are all not immediate measures. This can be supplemented with the existing controlling measures. That's not as a treatment, but as a supportive measures. There are various other measures also, including tannic acid, and these are all things which actually work on the mechanism of precipitating the surface protein. So that's tannic acid, all these alums and all these materials actually surface the actions mainly on the soft tissue, the gingival margin loose and things like that can be controlled with these agents, where they're actually acting by precipitation of the surface protein, precipitation of proteins. Well, Abjad is, I know all of you are aware of it. This is something what you should be having in your clinic. You should have, because it's very cheap also. Something, and in case whenever it's needed, whenever it's to be applied, it has to be kept in the socket. Now, how do you keep it? Now, you can take in either a small piece, or you can take it as a big chunk. Just dip it a little bit saline, use a tweezer and place it in the socket. Once you place it in the socket, you can place a figure of a suture on top of it to support so that it doesn't actually get dislodged immediately. So this is the way how you have to do. So never stuff your socket too much with the Abjad. Abjad should be something like it should be given adequate space to expand. So basically, when you just dip it in saline and you can place it there. That's about management of post-extraction bleeding. But these are all other agents. It's called Surgicel. It's too costly for the regular management. I would recommend, if possible, if you can have this regular cot. It's costing you around 18,000 to 20,000 rupees. But the advantage is it's got multiple tips of multiple sizes and shapes. It's a similar, it's got a monopolar and a dipolar, both that's available. Advantages, you can use it for various procedures. For example, if you want to just cut the operculum, on operculectomy, on the distal aspect of it, sometimes when you do want to frenectomy, all these different tips can be used for using a periapical surgery, maybe an episectomy to do a curettage at the periapical area. All these small instruments can be used, and it's very effectively, and it controls the bleeding. Definitely a little bit of postoperative healing discomfort will be there, but then hemostasis can be very well achieved. Well, let's move on to the next presentation and next topic. That's TMJ dislocation. Well, in TMJ dislocation, what are the causes? It could be an abnormal force application by the extraction forceps or the elevators. And you do in the mandible, when you don't give a support, adequate support for the mandible, this is all possible. And in some patients where they have this history of chronic dislocation, then that's also, they are also prone for dislocation during the procedures, and very lengthy procedures where in which the patient has to be kept mouth open wide for a longer period of time. So these are the causes usually, which is actually resulting in this complication of TMJ dislocation. Now you should know what happens and how it's the features, how does it look like, how can you identify. Patient will have definitely an open mouth appearance because the patient can't close the mouth, it's out of the glenoid fossa, the condyle is out of the glenoid fossa, and then it will be very tender, that particular area will be very tender, there'll be drooling of saliva, and extraordinarily at the glenoid fossa area, there will be depression, the pre-auricular area. If you palpate at this area, you can make out a small depression there because the condylar head is slipped out of the condylar fossa, and our aim of treatment is to put the condyle back in the fossa and make sure the occlusion is got back in position and the mandible is brought back in the position. Now this is how it looks like. Okay, as you can see on this picture, this is your normal anatomy wherein which the condyle is resting in the condylar fossa, and this is how in case of a dislocation wherein which the condyle which was here has actually slipped outside and moved out of the fossa. So this is how a dislocation appearance, and this is our normal appearance. Now our aim, our intention is to get this dislocated condyle from there, and we have to get it downwards, backwards, and upwards. Okay, that's the direction. The dislocated condyle has to be brought downwards, backwards, and upwards so that it rests finally in the glenoid fossa. So that's your aim of treatment. Now, for example, this is a case of a TMJ dislocation, which you can see very well open appearance. So how do you manage? First and very important, what you should understand is the need for an anesthesia, because once a TMJ is dislocated, patient is going to have severe pain because all the muscles are gone into a state of severe acute spasm. So it's going to be really painful manipulating the temporomandibular joint. So anesthesia is a must. So anesthetic technique can be used different anesthesia, because the regular inferior nerve block is not going to get your adequate anesthesia, because you want to anesthetize the area of the temporomandibular joint and the muscles out here. So only a high anesthetic technique, maybe a Gauguin's technique, which is seen in the picture here, wherein which the needle actually hits the pterygoid fovea in front of the neck of the condyle. That is one technique what you can do. The other one is basically the classical auriculotemporal nerve block. When I talk about auriculotemporal nerve, that's very effective because you just have to prepare the surface of the skin of the temporomandibular area, and then you can palpate the condyle. Okay, you can palpate the condyle with the hand, because you can move the patient's jaw like this. You can definitely palpate the condyle, and the posterior border of the condyle has to be felt. Opening, closing has to be done, and you should bring your finger down along the posterior border of the condyle, posterior border of the ramus, and to a level of your tragus of the ear, about 1 to 1.5 centimeters below the tragus of the ear. Till there, you remove your fingers down in the palpatory motion in the posterior border of the mandible. And then at that particular point, you can see, then this is how it's being done, as I told you. Now ask the patient, the mouth is already open, and you can palpate the condyle inferiorly until there is the neck of the condyle. I told you what I was doing, the neck of the condyle, and then 1 to 1.5 centimeters below the tragus. Till that area, get your palpating finger down, and then you can take a long needle, a half an inch, your regular insulin needle, a half an inch into 26 gauge into half an inch needle is used to insert a needle, and then you can use about 2 to 3 ml of local anesthetic solution, has to be deposited inside. Okay, that's the basic technique. I tell you once again, palpate the head of the condyle, the posterior border, along the posterior border of the ramus, just bring your finger down to a distance of 1 to 1.5 centimeters below the tragus of the ear. That's a point of entry. At that point of entry, you should inject the needle about depth of inside. It has to go inside about 1 to 1.5 centimeters. It goes inside, and then the aspirate and deposit about 2 to 3 ml of local solution. That gives a auriculotemporal block, and it's a perfect anesthesia of the temporomandibular joint. So you can do any sort of manipulation. Now, if it's a bilateral temporomandibular dislocation, you have to give bilateral auriculotemporal nerve block. If it's a unilateral, definitely. So as the situation arises, you have to give us this the diagrammatic representation what I was talking about, palpating and then getting down, and this is how the angulation how it has to go upwards and anteriorly in the final position. Okay, that's your auriculotemporal nerve block. So once you have achieved anesthesia, then it's procedure, the manipulation part. You can stand in front of the patient, use a gauze piece so that and place it on the posterior part of the molars on either side, so that when you apply downwards pressure, I told you the direction what you want is downwards, backwards, and upwards. So you're going to apply posteriorly a downward pressure, so it's your finger is not going to get cut, and your by the accidental closure of the mouth. That is something what you should be very careful of. So you always use a gauze, keep gauze in the posterior part of the lower, and then only apply pressure, downward pressure, the posterior region. Okay, that's a arrow which is showing the downward pressure. And then in the same time, with the other fingers, you are actually lifting the chin region there. So basically, you're trying to, float the mandible down. You're going to try to lock bring the mandible down, the posterior as well as the anterior is, you're trying to lift it up. So you're giving a total movement which is going to favor the movement of the mandible into downwards, backwards, and upwards. This is again a direction you can see as the downwards. Okay, the direct force of and the molar region downwards, and then backwards, upwards. This is what you have to do. This is a moment, or this is a movement that you have to do to get the mandible back in position. Well, once you get the position, but your TMJ is back in the condyle, you can see that then there's a normal closure. There's no deviated closure. There's a normal closure. Now you have to stabilize that mandible in that particular, because your mandible is stretched beyond limit. The ligaments are all sort of hurt and sort of disturbed. So you have to get in stability for that particular mandible. So you can either use a gauze like this. You can wrap around the chin and connect it to the vertex of your scalp behind, because you should not come too much anteriorly. So what happens? It just slips down and should not go too much posterior. Also, what happens? It goes down the neck. So a vertex should be the area where you should be focusing upon wrapping around. So the chin of the mandible, the vertex, 1 or 2 rounds like that, and then you can put a safety pin, or you can put a connector, you can put a tape here, and then use this part again to go around the forehead, so that you get a double stability like that, 2 rounds, and then finally you can stick it with your sort of paper tape, or you can use your pins or anything of that sort. So basically your mandible, your dislocated mandible is put back in position and stabilized by a bandage. Now this has to be kept for 3 to 4 days at least minimum, so that the earlier, the advantage of this now, if you are using a elasticated bandage, now this is a cheaper version wherein which you can use gauze. You can also use another technique in which you stand in front of the patient, and you can use the reverse method. Okay, instead of applying, keeping a thumb inside, you can put your index finger inside towards the posterior aspect, and then give a downward force. Same way, downward force, and that's another one technique. Same way, you can stand behind the patient and then keep both the thumb of the inside, and then try to press it down and try to lift it. So whichever is convenient for you, basically your intention is to drive the mandible downwards, backwards, and upwards. So that's the direction of the force that has to be given. Instructions to the patient as far as analgesic anti-inflammatory is to be given, because it's going to have severe pain post-operatively. It's going to have a severe inflammation related discomfort also. So analgesic anti-inflammatory has to be given. Well, muscle laxants is it can be recommended, no harm in it, but the problem with muscle laxants is because it doesn't have a specific joint related action alone. It's got a overall action on the central nervous system where it depresses all the muscles. The patient would be actually feeling a bit lethargic, and so such patients, if you're prescribing muscle laxants, you ask them not to drive vehicles and things like that. So that's the only problem. Patient would complain of fatigue and a little bit of lethargy. That's the main problem. And diet, of course, for a few days, patient has to be advised to take only soft diet, because you want the joint to be given rest. You don't want the ligaments to be too much engaged by hard foods and things like that. And care for 2 weeks definitely has to be there, so that you have to prevent any episode of chronic dislocation again. So that's basically the 2 conditions what we have discussed so far. And then the next what we have is about the dry socket.